This is Dr. Demarchena continuing with Aaron Cohen on mitral stenosis. We have the drawings of the mitral valve that's now become inflamed with rheumatic fever. This has caused commissural fusion, and as the commissures have fused, they basically restricted the opening of the mitral valve more and more. So the mitral valve is now extremely restricted in its capacity to move. It actually domes up in the lateral view and allows blood only to go through that central little aperture in the middle. This causes pressures to really elevate inside the left atrium, and this causes the left atrium to actually become quite enlarged. Um, and pressures are much higher in the left atrium. So let's take a case of severe mitral stenosis. In a case of severe mitral stenosis, the left atrial pressure, which is normally 8 to 10, now goes up into the 20 range, but the left ventricular pressure tracing remains the same, or actually the diastolic pressure in the left ventricle sometimes can get a little lower because there's so much restriction of the pressure for filling across the mitral valve. So now you can see that here, instead of having no gradient across the mitral valve, we have a 12 millimeter gradient across the mitral valve. So the pressures are so high in the left atrium that the left atrium never really totally empties during the diastolic phase, and the mitral leaflets stay open. And this is going to be very important when we go over the exam later, explaining some of the findings of the exam. But let's go look at the hemodynamic significance of this when we look at pressure tracings again. So first I'm going to just draw the pressure tracing. This is your ventricular diastolic phase, isovolumic contraction phase, aortic valve opening. Now I'm changing the scale on my paper. The paper is going to move faster so that I can expand my isovolumic relaxation phase. So instead of going straight down like I normally draw it, now I'm going to have it go over time longer. In reality, this is happening over a short period of time. So now I'm going to superimpose on it the left atrial pressures again, like we talked about in the previous lecture. So again, in the normal, this would be atrial contraction. That would be your A wave. You would have your B wave as the left ventricle, as the left atrium fills. You'd have mitral valvular opening, and then left ventricular filling, which would all take place. Now we're going to go ahead and give different degrees of pathology. So as you start developing more and more mitral stenosis, your pressure in your left atrium begins to increase more and more. And that because of that, there's always a slight lack of emptying of the left atrium. So the left atrial pressures always stay higher than their left ventricular pressure tracings as you get sicker and sicker degrees of mitral stenosis. So here now we're going to have a moderate mitral stenosis, and it still leaves a higher pressure tracing. And then finally we're going to give a real marked mitral stenosis. Now why am I drawing this in such a funny pressure tracing? Now remember that this was left atrial, aortic valvular closure here. So this is A2. Now, as we talked about before, mitral valvular opening in a normal patient doesn't generate a sound. So in blue here, this would be a quiet event. But as you get stenosis, the pressure tracings, the pressures in the left atrium are higher, and so the mitral valve is dying to open. It's dying to try to release the pressure that is holding back in the dike of the new stenosed mitral valve. And so as soon as the isovolumic relaxation phase allows the left ventricular pressure to drop below left atrial pressure, the valve jumps open because the pressures are so high inside the left atrium. And now this normally um, silent event is now audible. So here we'll do this one here, and we'll do this one here. So what is this new audible sound that we're hearing? And this is what we call the opening snap. Now the reason that I expanded time here for you could see the different opening snaps is so we can look at a very important physical exam finding in mitral stenosis. And that is that, first of all, there is an opening snap, but on top of it, as the mitral stenosis becomes worse and worse, the time period between A2 and the opening snap becomes less. So in real severe MS, there is a very short interval between A2 and the OS, or the opening snap. Now, this is happening over a microsecond, okay? You have to really train your ear to hear this. And then, and actually, as the auscultatory skills have been lost with more and more technology, it's very difficult for people to train their ears to hear this. But um, good clinicians can listen to the A2OS time period and be able to grade the severity of AS. Okay, so when we look at the physical exam of, mitral stenosis, the first thing we want to make sure that we realize is that there is an OS, and two, that the severity of mitral stenosis can be graded by the distance between A2 and OS. So what else can we hear in the physical exam? Now, as you notice here in what we drew, um, the, um, the pressure in the left atrium is a little higher than the pressure in the left ventricle in a person with worse and worse MS. And so because of that, if the valves are still have certain degree of pliability still, and they never really totally close, when now the pressure of the left ventricle augments during the isovolumic contraction phase, there is a much higher pressure in the left ventricle at the time that the mitral valve is supposed to close, and it shoots the mitral valve close. This causes the normal S1 to become accentuated. And so another important clinical finding in in uh, in MS is that there's an accentuated S1. Now let's talk about the murmur of mitral stenosis. Actually, I'm going to do it right here. So, um, so here we have our A2 occurring. Actually, we're not going to do it right here. We're going to go to another screen. So we already have an accentuated S1, so a larger S1 than normal. Systole is silent because nothing's occurring during systole. We have our A2, which is normal. And we have our OS. Depending on the severity of mitral stenosis, this is shorter or longer, as we spoke about. Now, the murmur of mitral stenosis It's a low frequency, very rumbly murmur, difficult to auscultate. You really have to hear it over the mitral focus, and sometimes you have to turn your patient on left lateral decubitus in order to hear it better. And this will decrease just like the pressure gradient drops as the left atrium empties. And then if the patient's still in sinus rhythm, when the left atrium contracts to generate the A wave, there will be a slight accentuation of the murmur. So the murmur will be a low frequency murmur that will be a growly murmur with accentuation before the next um, S1. And so if you were to hear that murmur, it would be like, it would be an accentuated murmur, a rumbly murmur that accentuates at the end of diastole. Whoops, this is S1. Now, other physical findings that we see as the left atrial pressures go up because of the mitral stenosis, the pulmonary artery pressures go up, and so your pulmonic sound is accentuated. So you actually have an increased P2. So if you were to compare it to your A2, your P2 would be accentuated. If you were to feel the patient's chest, you rarely feel the murmur because it's such a low frequency murmur, but you sometimes will feel the pulmonary artery, which has become large because of the pressure elevation in the atrium. And then, if the patient develops secondary right heart failure from the long-standing mitral stenosis, you can hear rows in the lungs, or you can hear you'll hear rows in the lungs from the left heart failure, but from the right heart failure you'll see neck vein enlargement and JVD. Okay, so again, summarizing the physical exam of patients with mitral stenosis, there'll be an enhanced S1, there'll be a opening snap, and the severity of MS can be judged by the distance between A2 and the opening snap. There'll be an accentuated P2. There will be a rumbly low frequency murmur. They will have presystolic accentuation if the patient's still in sinus rhythm. And again, there'll be an enhanced S1. Thank you very much.